I'm Jason Shire, and welcome to Quick Gastro. This is a video on the internet, so we shouldn't be using this to diagnose or treat people with medical conditions. Read the fine print, but mostly this is just for education. When we teach young doctors about a clinical situation, we often ask, what should we do next? But a better question should be, why should we do this? Because once we understand why something is more or less helpful, we can start taking a more nuanced approach in providing better outcomes on a more personal level. So let's talk about biologic levels in antibodies. We start with a question. Your patient with ulcerative colitis is on infliximab 5 milligrams per kilogram every 8 weeks, and it's done well for years. Over the past few infusions, they note that it's not working as well. Specifically, there are more symptoms for the week prior to infusions. Then she gets the infusion, and within hours, she feels better and the process repeats itself. So the natural question in this situation is, what should you do? But as we covered, I want to discuss why we should pick each option. The first step remains rule out infections. And the second step remains confirm that it is active IBD, which is typically done with colonoscopy, fecal calprotectin, or imaging. But once we know that this is uncontrolled ulcerative colitis, we start working through the process of figuring out why this once effective medication is now less so. The differential includes underdosing, changing disease severity or phenotype, immunity to the medication, the mechanism of action is no longer effective, or a medication interaction. We can answer some of these questions by checking the level of the medication and for the presence of antibodies. This is a reactive process to figure out what went wrong, and we will talk about a proactive therapy approach in the future talk. Some of the assays that we use only detect antibodies if there is a low enough level of the medication so that the antibodies are free. When the concentration of medication goes up, there's no free antibodies and we get a false negative on the report. So we check the levels at the nadir of the concentration, which is just prior to the infusion. This also allows a fair bit of reproducibility. If we check at the peak and compare it to the nadir, or any place in between, we may get different levels. In my experience, it takes 2 weeks to get the results back, so it's rarely helpful for the next dose. Remember, we can check it earlier, but we're going to push the levels higher, and this may lead us to overestimate the concentration of the medication and miss the presence of the antibodies. Interpreting results are straightforward. The first thing to do is that I focus on the presence of antibodies. If there are antibodies present, almost universally we'll be changing the medication, as the patient has developed immunity to the medication. There is a caveat that if there are low levels of antibodies and detectable levels of medication, we can recapture response by increasing the dose and possibly adding an immunomodulator. But this response is rarely durable, and usually within the next few years we have to switch agents. The levels are less important, and that's because we really don't know what to do with them. We used to hope for a level greater than 3.5 for infliximab. Later on, data said that maybe they did better if it was above 5 or 6. Now we think that if you have a fistula, maybe above 7 is a better number. Basically, it came down to some people in the lowest quartile levels had the least chance to respond to medication, and the people in the highest quartile were most likely to respond. The issue is that plenty of people in remission are in the lowest quartile, and plenty of people who are active are in the highest quartile. So it requires more understanding than that. In addition, I would rarely decrease the dose because the level is too high. Chances are that if we have a high level, they're doing fine, and we got there on purpose, so decreasing will likely bring back the inflammation. When we interpret the labs, we have 3 options. We can increase the dose, switch the medication in the same class, or switch to a new class of medication. If we find out there are no antibodies and a low level of medication, then increasing medication may be helpful. If we have antibodies and a low level of medication, then switching medication is going to be needed. The 2 key points are, number 1, we can switch within the same class since they are not immune to the whole class, just one agent. And 2, due to the nature of biosimilars, if you are immune to the originator, then you are immune to the biosimilar and vice versa. Lastly, if you have no antibodies and plenty of medication in the system, then increasing the dose or switching to something with the same mechanism of action is unlikely to be helpful. So switching to a different mechanism of action is most likely going to recapture response for you. On a different topic is proactive drug monitoring. This is the process of routinely checking the drug level towards the end of induction, and if possible, increasing the dose of medication preemptively to increase the chance of long-term remission. This is a topic that won't be addressed today, but the short answer is that, as of the making of the video, this is a concept that has generated a lot of interest but failed to demonstrate in research to produce a significant benefit over reactive monitoring. So this is drug monitoring. This is a concept that will come up in many IBD patients, and knowing how and why we make changes can lead to significant improvements in their quality of life. That's the end of this topic. Be good to each other.